Good morning, everybody. I am Dr. Prithiviraj, Department of Biochemistry. Today we are going to discuss about galactosemia. So, galactose metabolism. The learner will be able to know about at the end of the class. You have to know about galactose metabolism, source and absorption, describe galactose metabolism, inborn, inborn errors of the galactose metabolism, identification of galactosemia, management treatments. Galactose is a hexose, a reducing monosaccharide. Galactose is a hexose. It is a reducing monosaccharide. In 4 epimerase, maybe in 4 epimerase of glucose, glucose and galactose differs only in the orientation of H and OH on carbon, fourth carbon. See, this is left side, you can see this is glucose, right side that is galactose. See, this is only changes H and OH in carbon atom, fourth. So that is the only changes in glucose and galactose. Okay, very small changes only in the fourth carbon atom. There will be changes in H and OH. But you can differentiate in the diagram. You can see. Okay. So galactose is found in mainly in milk and milk products, mainly whey protein, curd. Today we are using curd, cheese, and milk products. It's a higher source of galactose. It's found in the milk products. Major source of galactose is lactose of milk, galactose and glucose. So see here, what is lactose? Galactose and glucose joined together form lactose. So this is lactose, the structure of lactose. The lactose, the enzyme, in the presence of beta galactosidase, go to the glucolysis, glucose goes to the glycolysis and beta D-galactose. This is galactose by the in presence of beta galactosidase goes to glycolysis and this is beta D-galactose. So this is the lactose. Okay. Major source of galactose is lactose of milk. Absorption. How it will be absorbed. Rate of absorption of galactose is less than that of glucose. The rate of absorption of galactose is less than that of glucose. Absorbed from the intestinal lumen. It's mainly absorbed from the intestinal lumen into enterocyte by carrier mediated facilitated diffusion. Carrier mediated facilitated diffusion. That is GLUT5. That is called GLUT5. I'll show you to the next slide. Secondary active transport by sodium dependent glucose transporter, SGLT1. This is called SGLT1. So absorbed mainly in intestinal lumen into the enterocyte by carrier mediated facilitated diffusion, that is GLUT5. Secondary active transport by sodium dependent glucose transporter, SGLT1, absorbed into capillaries from enterocyte into GALT2 by facilitated diffusion. So almost entirely metabolism by the liver cystosol of hepatocytes. Almost entirely metabolism by the liver cystosol of the hepatocytes. So mainly first it absorbed from the intestinal lumen into the enterocyte by carrier mediated facilitated diffusion, that is called GLUT5. Then secondary active transport by sodium dependent glucose transporter, SGLT1, absorbed into capillaries from enterocyte through GALT2 GLUT2 by facilitated diffusion, almost entirely metabolized by the liver cystosol of hepatocytes. Next we can see. So this is, see here. So this is lumen of intestine. In the lumen of intestine, this is intestinal epithelial cells. In the epithelial cells, this is brush border of the intestinal lumen, and this is the this is the capillaries. This is the capillaries, brush border, the lumen of intestine. This is intestinal epithelial cells. The yellow color is the intestinal epithelial cell. This is lumen of the intestine. This is a capillary. Okay. So this is a chondroluminal membrane. This is a cell membrane. Chondroluminal membrane. Okay. So now you can see glucose, fructose, also glucose enter to the chondroluminal membrane by GALT5. This yellow color is a GALT5. It is fructose, also glucose enter into the chondroluminal membrane. Another one is SGLT1, glucose and galactose, along with sodium, it enters to the chondroluminal membrane in glucose and galactose and sodium. So then from glucose and galactose enter to the capillaries through facilitated diffusion. The yellow color is a cell membrane. That's membrane we having facilitated diffusion, that is GALT2. From that it enters to the capillary glucose and galactose. And here sodium and potassium ATPase pump. So it will automatically sodium will come out, potassium will go to the opposite side. So this is a sodium potassium pump. This is, and another one is a sodium dependent co-transport. The pink color is sodium dependent co-transport. That is glucose and galactose enters through the along with the sodium. That is sodium dependent co-transport. You can see what are the transporters in the cell membrane. Lot of transporters are there in the cell membrane that you will see in the cell membrane. So now here is glucose and galactose enter to the sodium dependent co-transport. It will along with the glucose and galactose, sodium also will come. It's a pink in color, that is SGLT1. These are all the absorption of the galactose. Understand? Then Lee-Lawyer pathway. Lee-Lawyer pathway. What is Lee-Lawyer pathway? Short notes. They will ask in some short notes Lee-Lawyer pathway. Galactose converted to galactose 1-phosphate in the presence of galactokinase enzyme. Galactose converted to galactose 1-phosphate in the presence of galactose kinase. Galactokinase is the first enzyme here we are used. For that we are used one energy ATP to ADP, adenine tri to adenine diphosphate. We are using one energy here. Then galactose 1-phosphate converts to glucose 1-phosphate by the enzyme in the presence of uridyl transferase. First, there is one galactose kinase. Here, uridyl transferase enzyme converts glucose 1-phosphate to glucose, galactose 1-phosphate to glucose 1-phosphate. Then glucose 1-phosphate converts to glucose 6-phosphate in the presence of phosphoglucomutase. Phosphoglucomutase enzyme. The presence of phosphoglucomutase enzyme, glucose 1-phosphate converts to glucose 6-phosphate. From glucose 6-phosphate, autocatalysis will go to glycolysis. This is Lee-Lawyer pathway. Glucose to glucose 1-phosphate, galactose to galactose 1-phosphate, galactose 1-phosphate to glucose 1-phosphate, glucose 1-phosphate to glucose 6-phosphate, glucose 6-phosphate to glycolysis. This goes to glycolysis. Understand? This is more important pathway. They will ask in short notes also. Then galactose metabolism. How it metabolism is happen? There are no metabolic pathways to metabolize galactose. There is no catabolic pathway to metabolize galactose. So the strategy is to convert galactose into metabolite of glucose. So directly, it means directly galactose won't be metabolized. So it will, it is converts to glucose. Galactose converts to glucose. That is into a metabolite of glucose. Galactose into a metabolite of glucose. Directly it won't get metabolized. So it converts to glucose into a metabolite of glucose. You understand? The galactose metabolism. So this is step 1, phosphorylation of galactose. This is step 1. This is phosphorylation of galactose. Step 1, step 2, step 3, step 4, step 5 and step 6. Totally we have 6 steps of metabolism of galactose. Step 1, phosphorylation of galactose. This is galactose. This is galactose. Galactose, in the presence of galactokinase enzyme, it converts to galactose 1-phosphate. Here we are using one energy, that is adenine triphosphate to adenine diphosphate. We are using one energy here, the presence of galactokinase. This is galactose 1-phosphate. This is the step 1. Step 2, activation of galactose to UDP galactose by UDP glucose. Step 2, activation of galactose to UDP galactose by UDP glucose enzyme. How? This is galactose 1-phosphate. It will converts to UDP galactose. This is UDP galactose. The presence of galactose 1-phosphate, galactose 1-phosphate uridyl transferase enzyme. Galactose 1-phosphate uridyl transferase. Here UDP glucose is converted to glucose 1-phosphate. Then it goes to phosphoglucomutase. And simultaneously, it will go phosphoglucomutase. The presence of uridyl glucose converts to glucose 1-phosphate. The presence of phosphoglucomutase converts to glucose 6-phosphate. This glucose 6-phosphate automatically it goes to glycolysis. Automatically it goes to glycolysis. So here galactose 1-phosphate, the presence of galactose 1-phosphate, uridyl transferase enzyme converts to UDP galactose. This is UDP galactose. This is step 2. Step 3, epimerization of UDP galactose. Epimerization of UDP galactose. UDP galactose, epimerization of UDP glucose, UDP galactose 4 epimerase. That is called UDP galactose 4 epimerase. The presence of UDP galactose 4 epimerase, UDP galactose converts to UDP glucose. UDP galactose converts to UDP glucose. Presence of UDP galactose 4 epimerase enzyme converts to UDP glucose. From UDP, then this is step 4, formation of glucose 1-phosphate. Formation of glucose 1-phosphate. The UDP glucose converts to glucose 1-phosphate. The presence of UDP glucose pyrophosphorylase. UDP glucose pyrophosphorylase enzyme. Presence of UDP glucose pyrophosphorylase enzyme. The UDP glucose converts to glucose 1-phosphate. This is step 4. Step 5. Formation of glucose 6-phosphate. Glucose 6-phosphate, how it forms? Glucose 1-phosphate converts to glucose 6-phosphate in the presence of phosphoglucomutase. Phosphoglucomutase enzyme. In presence of the phosphoglucomutase enzyme, glucose 1-phosphate converts to glucose 6-phosphate. So the glucose 6-phosphate automatically go for glycolysis. This is the metabolism of galactose metabolism. This is galactose metabolism. Directly galactose cannot be metabolized. So it converts glucose, then glycolysis will happen. There are totally 6 steps are there in galactose metabolism. Step that you have to write in the 6 steps. Step 1 is phosphorylation of galactose. This is galactose to galactose 1-phosphate. Step 2, activation of galactose to UDP galactose by uridyl transfer UDP glucose. UDP glucose. This is the step 2. This is glucose 1-phosphate converts to UDP galactose. Then step 3, epimerization of UDP galactose. Though UDP galactose converts to UDP glucose in UDP galactose 4 epimerase. This is step 3. Then step 4, formation of glucose 1-phosphate. UDP glucose galactose to UDP glucose to glucose 1-phosphate. The presence of UDP glucose pyrophosphorylase enzyme. Formation of glucose 6-phosphate. Glucose 1-phosphate converts to glucose 6-phosphate. The presence of phosphoglucomutase. Step 6, glucose 6-phosphate automatically converts to glycolysis. These are the steps in the galactose metabolism. These steps you have to write in the short notes. Inborn errors of galactose metabolism. What is inborn error of galactose metabolism? Inborn errors, this is most important. In inborn, children are having errors in the metabolism. Galactose is the main, one of the important inborn errors, that is called galactosemia. Galactosemia. So this is the diagram shows what are all the findings in the galactosemia. From head to toe, you can see that is mental retardation will be there. Then congenital cataract will be there. What is congenital cataract? Congenital means from the birth, both eye, bilateral. The cataract means, what is cataract? Cataract means opacity of the lens. Normally, cataract will happen only at the elderly age. Some injury or some ulceration, any other causes, only in the elderly age, more than 40 years, cataract will be formed. What is cataract? Opacity of the lens is called cataract. It will be in elderly age, but in inborn error, in the from the birth, they will get opacity of the lens. The opacity means white coloration in the lens. You can put a light in the eye, you can see the lens, it will be like milk or like light white in color. So that is the opacity of the lens, that is cataracts. Then jaundice will be there. What is jaundice? Yellow coloration of the skin. Skin will be yellow in color. Conjunctiva, nails, all the places will be yellow in color. So that is the jaundice, you can find out. Then hepatomegaly. Anything, the galactose accumulate in the liver. So the liver will be enlargement. Enlargement of the liver. That is the hepatomegaly. So hepatomegaly means enlargement of the liver. Liver will be big in size. It will be palpable. Just will in the abdomen you can pressure and check by palpitation method. You can see the liver will be hepatomegaly, big liver, that is called hepatomegaly, because of accumulation of the galactose. Then kidney damage. How you know kidney damage? In the urine, you will get galactose and amino acid in the urine. Due to kidney damage, the galactose and amino acid in the urine. So we can find out there is a damage in the kidney. Then hypoglycemia. Hypo means low. Glycemia means sugar. Less sugar in the blood. So these are the signs and symptoms of the galactosemia. From the head to toe, you have to go. Mental retardation, congenital cataract, jaundice, hepatomegaly, kidney damage, galactose and amino acid in urine, and hypoglycemia. These are all the symptoms of galactose, inborn error of galactose metabolism, that is galactosemia. This is a galactosemia is a autosomal recessive disease. It's an autosomal recessive disease. It is 1 in 80,000 birth. 1 in 80,000. 80,000 births will get one person like this. It's an autosomal recessive disease. 1 in 80,000 births. Galactose metabolism. So glucose is converts to glucose 1-phosphate. So galactokinase enzyme, if absent or any problem in the enzyme, galactose cannot be converted to galactose 1-phosphate. This is non-classical galactosemia. Absence or deficiency or problem in the galactokinase enzyme, that is non-classical galactosemia. Number 2, galactose 1-phosphate convert to UDP galactose. That is in presence of galactose 1-phosphate uridyl transferase enzyme. In the absence of or deficiency or absence or any obstructions in the galactose 1-phosphate uridyl transferase, that is called a classical galactosemia. Any obstruction here, that is classical galactosemia. The third one is UDP galactose to UDP glucose, that is epimerase enzyme. Any absence in the epimerase, this is the third one. So we are having non-classical galactosemia, that is galactokinase and epimerase. Classical galactosemia, that is absence or deficiency or problem in the galactose 1-phosphate uridyl transferase. These are all the galactose metabolism. Three forms of galactosemia. One is classical, that is galactose 1-phosphate uridyl transferase. That is serious. The symptom will be serious, means symptom will be more, and the milder form and rare form. The milder form is galactose kinase absent. Epimerase is the rare form. Okay, due to deficiency of enzyme in the conversion of galactose to glucose. Main thing, due to deficiency of enzyme in the conversion of galactose to glucose. Galactose 1-phosphate uridyl transferase, that is GALT. Classical galactosemia, GALT. That is 95% of patient. It's a highly risk. And galactokinase, galactokinase. It's a mild form. It's a 5% only occurs. And UDP galactose 4-epimerase, GALE. It's a very milder form and is very rare form. These are three forms of galactosemia. Symptoms, signs of classical galactosemia. Already we saw the diagram and some symptoms I will tell. Early presentation. Earlier it will be baby will get vomiting and loose motion and vomiting and diarrhea, lethargy. The baby will very weak, and then if you check, hypoglycemia will be there, less sugar in the blood. Hypoglycemia will be there, and the failure to thrive. Don't be cry. So it's inactive and don't cry. The baby won't inactive and failure to thrive. Then jaundice. I told jaundice. So yellow coloration of the skin, sclera, nails. You can see yellow coloration. Then congenital cataract. Accumulation of dulcital. So the accumulation of the dulcital in the lens. That means it will produce opacity of the lens, that is from the congenital, from the birth. That is congenital cataract. Accumulation of the dulcital. The late presentation. In late, mental retardation of the baby. Mental retardation, hepatomegaly and liver failure. Hepatomegaly means accumulation of the galactose in the liver. So enlargement of the liver, that is hepatomegaly. So finally liver failure. Then aminoaciduria. Amino acids, it will from the urine, it will come because of renal failure. Because of renal failure, amino acid will come through the urine. This is aminoaciduria. This is a renal failure. All see in the diagram. Galactose and amino acid in the urine. Kidney damage, hepatomegaly, jaundice, congenital cataract, mental retardation, hypoglycemia. These are all the classical symptoms of inborn error of galactosemia. Causes for symptoms, signs of galactosemia. Accumulation of galactose 1-phosphate. Accumulation of galactose 1-phosphate. It depletes liver of inorganic phosphate. Accumulation of galactose 1 phosphate. The causes of symptoms, signs in galactosemia. It depletes liver of inorganic phosphate. It inhibits GALC. That is one of the enzyme. It inhibits GALC. It inhibits glycogen phosphorylase, hypoglycemia. It inhibits glycogen phosphorylase. That is causes for hypoglycemia. Gets deposited in liver and renal tubule, causing their failure. It gets deposited in the liver and the renal tubules. It causes their failure. That is the renal failure, liver failure, and the hepatomegaly. It gets deposited. So, the galactose is deposited finally in the liver and the renal tubules. It is renal failure and liver failure. Accumulation of galactose leads to galactosemia. Finally, accumulation of galactose leading to galactosemia. Galactose reduced galactose reduced to galcitol. That is called dulcitol. Galactose reduced to galcitol. It forms galcitol. The galcitol is converted to dulcitol. Dulcitol only will be deposited in the lens. So the more deposited the galactose reduced to galactidol. The galactidol converts to dulcitol. The dulcitol only deposited in the lens. That is cataract. This is the osmotic effect. It's irreversible osmotic effects of lens. That is congenital cataract. Galactose reduced to galactidol. Galactidol converts to dulcitol. Dulcitol will be deposited in the lens. It's irreversible cataract. Then brain damage. Irreversible even after dietary restriction. After dietary restriction also cannot able to irreversible brain damages. Diminished ATP, increased fragility of lysosomes, impaired oxoplasmic transport. Diminished ATP, increased fragility of lysosomes, impaired oxoplasmic transports. These are all the important things you can see. E. coli septicemia is common in babies. This galactosemia babies, they will mainly E. coli septicemia is common in babies with the galactosemia, as accumulated galactose can inhibit the leukocyte bacterial activity. The E. coli septicemia is common in galactosemia babies, as accumulated galactose can inhibit the leukocyte bacterial activities. Understand? Causes, these are the cause for signs and symptoms of galactosemia. So mainly accumulation of galactose, these are all happening. So cataract formation, same thing, cataract formation in galactose. This diagram shows nice cataract. When you light into the cornea, you can see the opacity of the lens. Cataract opacity in the crystalline lens of the eyes. When galactose accumulate, it reduces to galactidol, that is dulcitol. Galactidol exerts to osmotic pressure. The osmotic swelling of the lens and the epithelial cells of the lens will be occurs. Diagnosis of galactosemia. In urine, reducing substance positive after 2 weeks of birth. After 2 weeks of birth, you can check the urine. You will get reducing substance present in the urine. Can give false positive result in premature infants. So it give false positive results in premature infants. Another test we can see paper chromatography. Chromatography is the one of the important investigation. There is lot of types are there in this ascending, descending, paper, gel, many type of chromatographies are there. You will read at the time of practicals. So in paper chromatography, we are mainly used in this galactosemia diagnosis. Paper impregnated with galactose oxidase. Papers impregnated with galactose oxidase and low level of RBC galactose 1-phosphate uridyl transferase. In low level of RBC, galactose 1-phosphate uridyl transferase. Uridyl transferase is one of the important main enzyme for galactosemia. Then finally liver biopsy. In liver biopsy, liver damage you can see, fatty liver changes and cirrhosis of liver. Mainly liver damage and kidney damage because of accumulation of galactose. So fatty changes will be there and cirrhosis of liver. Specific test for galactosemia. For galactosemia, GALT activity, radioenzymatic analysis. GALT activity we can see by radioenzymatic analysis, isoenzyme pattern, isoelectric focusing. Isoenzyme pattern we can see isoelectric focusing and GAL 1-phosphate you can see in the spectrophotometry. GAL 1-phosphate you can check through the spectrophotometry we can check. Then urinary calcitol. In the urine you can check calcitol, urinary calcitol you can see in the urine. These are specific tests for galactosemia. Prevention and treatment. How to prevent and how to treat. Genetic screening for galactosemia. This is a prevention. So you can see the genetic screening for galactosemia. Early identification is most important. Early, you can identify earlier, as early as possible. You got to identify the signs and symptoms, how the baby is through or not, and have the baby's activities and the jaundice, the signs and symptoms we can check. Okay. Then removal of galactose source from diet. Removal of galactose source from galactose free diet you can give to the baby. Then you can, the symptoms, vomiting, diarrhea can avoid. Understand? Then lactose free milk formulas are available nowadays. Many formulas are in the market. So lactose free milk formula you have to give to avoid the galactose, understand, from the diet. Then like soya milk to be used until 5 years of age. The baby will reach up to 5 years. You can try to give soya milk. Gal 1-phosphatase, 4-pyrophosphate, pyrophosphorylase get active then by cell, active by then. So after 5 years, Gal 1-phosphate pyrophosphorylase gets active by itself. Okay, symptoms disease, but mental retardation is not residual because all symptoms will relieve, but once mental retardation can't be reversible. That is a residual. Okay. Then summary. These are important points. You have to take home messages like deficiency of galactose 1-phosphate uridyl transferase is the cause of galactosemia. There is 3 major are there. One is main one is classical galactosemia, that is glucose 1-phosphate uridyl transferase deficiency are absent or any issue. Okay, characteristic features of galactosemia are congenital cataract. So congenital cataract is the most important symptoms of characters of galactosemia. Generalized amino aciduria. In urine, amino acid will be there. Hepatomegaly, jaundice, finally mental retardation. These are the main characteristic features of galactosemia. Lactose-free diet from the mainstay of treatment. So lactose-free. If you give lactose, milk is the lactose. Give, the baby will vomit, loose motion, diarrhea, dehydration, coma, failure, death. So try to avoid the lactose free. So you can give soya milk. So mainly milk and milk products having galactose. So avoid galactose milk product. Then we can treat the. These are all our reference. Thank you. Thank you very much.